All right, hi, I'm Riley,
And I'm Gracie.
and today we're discussing an ethical question that speech language pathologists often face when managing dysphagia.
The question is it ethical to recommend diet modifications without an instrumental swallowing assessment when one is available but delayed?
Instrumental assessments can entail modified barium swallow studies or FEES, which allow clinicals to directly observe swallowing physiology.
However, in many healthcare settings, these assessments may not be immediately available due to scheduling delays, medical stability, or access to equipment.
This creates a clinical dilemma for speech language pathologists. Should diet recommendations be made immediately on bedside evaluation?
Or should clinicians wait for instrumental evidence before changing a patient's diet?
I will argue that diet modifications can be ethical in certain situations even without instrumental assessments.
And I will argue that making diet changes without instrumental assessment when one is available but delayed raises ethical concerns.
I says that it is ethical to make diet changes based on clinical findings and bedside findings when an instrumental is available but delayed. It is important to ensure that they are both temporary and necessary as the SLP. A reason for this can be due to an immediate safety risk. Diet modification can be used as an interim step to mitigate any safety risk with a thorough bedside eval. Per Simning, SLP assessment and treatment of dysphagia in the acute hospital setting can vary widely, and they may attempt PO trials with varying liquids or prefer it if there's no overt aspiration signs and no readily available instrumental. This can also be based on patient-centered care. If they request a diet change but an instrumental is delayed, you as the SLP must ensure that the diet texture modifications are necessary and effective prior to the implementation, and it needs to be discussed with the patient thoroughly and their physician to weigh risk and benefits. This is per AC, SLP, and audiology. It's important to document this interaction and assess plan of care when instrumental is available. This can also be ethical if the deficit is feeding based in comparison to a swallowing disorder. Per ASHA SLP medical review guidelines, oral stage dysphagia treatment may continue prior to the instrumental assessment. Overall, it is ethical, but it's important to conduct a thorough bedside eval and understand you are essentially going in blind, so take everything into consideration. You need to take in the findings, science and evidence, clinical expertise, and the patient's needs and wants prior to making diet modifications, and you need to put emphasis that these will be temporary and they are case by case.
Although bedside swallow evaluations provide helpful information, recommending diet modifications without instrumental assessment when one is available but delayed raises important ethical concerns. One major limitation of bedside swallow evaluations is that clinicians cannot directly visualize what is happening during the swallow. Because of this, decisions are often based on external signs such as coughing or throat clearing. However, these signs do not always reflect what is occurring internally. For example, silent aspiration occurs when material enters the airway without triggering a cough response. In cases like this, a clinician may incorrectly assume swallowing is safe when aspiration is actually occurring. Instrumental assessments such as MBSS or FEES allows clinicians to directly observe aspiration and understand the physiological reason it is happening, and that is referenced through ASHA. Another concern is potential negative impact of diet modifications on patients. Thickened liquids and restrictive diets can reduce hydration, decrease nutrition, and significantly affect quality of life. Research has also shown that patients often dislike thickened liquids and may drink less because of the texture, and that is from Steele in 2015. From an ethical perspective, speech-language pathologists are expected to follow the principle of non-maleficence, which means avoiding actions that could cause harm. Placing a patient on a restricted diet without objective evidence of swallowing impairment may unintentionally create harm rather than prevent it. When an instrumental assessment is already available but simply delayed, clinicians must instead use compensatory strategies such as positioning adjustments or smaller bites until the evaluation is completed. For these reasons, recommending diet changes without instrumental assessment can be ethically problematic when objective testing is soon available.